Hello everybody and welcome to Facebook Friday. It's Friday the 28th of May and I'm Kate Wakeland from Neuroendocrine Cancer Australia. So lots of you know me well. I'm the NET patient support nurse here for people in Australia affected by neuroendocrine cancers, and every week we hop in and do a Facebook Live on a topic of the week, and I'm very excited that this week we've got a guest expert with us. So I'm going to introduce you to Dr Sonia Fullerton a little bit more in a moment. But before I continue, just want to take this opportunity to acknowledge the traditional owners of the land that I'm broadcasting to you from, which is the land of the Wurundjeri people of the Kulin Nation. And so just wanting to take a moment to pay my respects to elders past, present and emerging. Those of you who know me well know that I love to go running along the Yarra River, which is called the Birrarung in the Woi-wurrung language. Haven't been out this morning yet, but I did manage to get out yesterday, which was awesome. And knowing that everybody is joining us from all 4 corners, all 10 corners of the country, and so just extending that acknowledgement to where you are joining us from today. So just before we get to Sonia, there's a couple of other things just to say today. The first thing is NETs, neuroendocrine cancers, are an incredibly diverse range of tumours. And so we have people in our Facebook group who might have had a very small, low-grade tumour completely removed with an operation. And we know that in that sort of situation, the prognosis, so what we're expecting to happen long term, is actually really, really positive, and your outlook is extremely, you know, compared to that of a normal person at your age, pretty much on par. We also have right through to the other end of the scale people who have really high grade, rapidly growing cancers throughout their body, and we know that there's probably a different situation for you in terms of prognosis and outlook. So we're going to talk generally today about palliative care. The relevance to you will be a bit different depending on what your situation is. So it's really important that you take what you can from this conversation, but please check it with your doctor. The last thing we want to do is make anyone worried or panicked that they are in a situation that they don't really need to think about at the moment. The other thing that I just wanted to say out loud is that this can be a confronting topic. Now, we're not going to talk doom and gloom. Well, I'm not expecting, it depends what questions you have for me, but I'm not expecting to be really talking about really difficult, confronting things today. But just the topic of palliative care can feel confronting for people, and especially if you're newly diagnosed and you've got a lot of things to get your head around. You know, this can be difficult. And so if you are watching this when you've got your kids around or loved people around, or you're having a hard day, if you're in Melbourne, you've just gone into lockdown, like it might be a hard time for you. We're recording this. It's available in the Facebook group ongoing, and it will be available later on via YouTube. So if this is not a good time, it's okay to opt out and not watch it right now. You might want to come back to it at a later stage. You might not, and that's absolutely fine. So you call the shots there, and this will be available for you when you're ready. So I think that's the 2 things that I really wanted to emphasize before we got going into the conversation. So just to check with your doctor, and everybody's different. This will be more relevant or less relevant, you know, for various members of our group, and also just check in with yourself and just see if you're up for the conversation right now. Fantastic to have you along. I can see some people have joined us and saying hi, which is awesome. But there's no pressure to deal with this today if today is not a good time. So Dr Sonia Fullerton. Sonia, you're from Peter Mac. Could you explain your role, please?
Absolutely. So hello everyone, it's great to be here today, and happy Palliative Care Week. I'm a palliative care physician, so that means I'm an internal medicine consultant who's specialised in palliative medicine, and I've been working for, gosh, it's about 25 years now. And I work at Peter Mac in a number of different roles, in outpatients, in inpatients, in consultation, and my job is to care for patients and their families who have a life-limiting illness.
That's a pretty broad statement. Sonia, I wanted to, you know, I think we were talking before we pressed go live on the video, and I was talking about one of the things that I'm hoping to get out of our conversation today is to dispel some myths about palliative care. So we'll be doing that as we go.
Yeah.
But I think, you mentioned life-limiting illness. So I've got, for example, one patient who was diagnosed with their neuroendocrine cancer in 1984.
Wow.
She's got, tumours. Her PET scan looks like she's been to a paintball convention. So technically on paper it looks life limiting, but she's very well. I think she's looking after grandkids, and when it's not COVID time, she's getting out and traveling and living a full life. So I'd actually really like to unpack, if we can, what that means, if that's not too tricky a question.
That is a tricky question, but I'm going to give it a bash.
Yeah.
So I think that people, when they hear the word palliative care, they automatically, their mind turns to end-of-life care, to the care of the actively dying person. And I absolutely do that, it's true, but probably only 10% of my job is caring for patients who are actively dying. And the other 90% is talking to patients about their physical symptoms, their emotional, social, spiritual needs, because we want people to be at home in the community as well as possible for as long as possible. So it might be that your friend who's had a diagnosis since 1984 is very physically well and doesn't have any symptoms that need to be assisted by the palliative care team, and that's absolutely fantastic. But if a time came in her illness where she was getting some more symptoms, then the palliative care team could be appropriate to be involved, help her address those symptoms, set up supports. The reason that gets me out of bed in the morning is to keep patients at home rather than them having to schlep into the emergency department in an ambulance. So that's, I think, one of the most important things, if you take home nothing else from today, that palliative care wants to keep people as well as possible for as long as possible.
Awesome. And so I think that's really great to clarify that it's not just about, although it includes care at the end of life, it's not just limited to that. So I gather from that, Sonia, that you might come in for a chapter of a person's illness, and then if that symptom becomes stable, that you might then not need to see them for some time.
Yeah, that's exactly right. So one of my main jobs is in the outpatient setting, and I think hopefully later we'll talk about the different types of palliative care that you can get. One of my main jobs is in the outpatient setting. So patients might come to the hospital to see their oncology team, and then they might come to see me at the same time, or I might go to the chemotherapy day unit to see them there, and we might manage their symptoms. And then after those symptoms are addressed and there's nothing more that I can add to their care, I will be so happy to discharge them from our service and send them back to their GP and their medical oncologist. And almost invariably at that time, the patient has had a good experience with palliative care and they know that they can contact us again in the future if they need to. One of the other big types of palliative care is called community palliative care, and that's mostly nursing, but medical and allied health as well, a service that can come to people's homes. And this is fantastic because we want to deliver our care to the place where the patient would prefer us to deliver it. So if the patient is unwell and not coming into hospital for treatment anymore, I do not want them to jump in the car and come to hospital to see me. Our teams will go out to their home in the community and help the patient and their family as well together to deal with the practical symptom management issues that might be involved. And that's a free service.
And so, Sonia, I've worked in hospital-based and community palliative care here in Victoria. But I do know that, like, every state's got its own little health system and health ecosystem. Is there any comments you can make, knowing that we've got people who have logged in from all over Australia, and we might even have some New Zealanders joining us as well? And I'm sorry, I've sprung this question on you. I didn't warn you that I might ask you.
Well, that's okay.
So it's okay to say, let's get back to that one another day. But is that across the board? So, for example, if someone lived in remote, Western Queensland or, up north in WA, is there still a community palliative care service?
Great question. So it's definitely better in the metropolitan areas. So in the city, I'm also from Melbourne. So in the city, every suburb is allocated to a particular area of a specialist palliative care community team. In the more rural areas, the palliative care services may be carried out by the district nursing services or the local health service that's available for that area. They may have a team that has an interest in palliative care, but they may not be formally trained specialist in palliative care, but they can then get information from the tertiary centres that are that work more closely with them. There's a really good thing that I do a lot. I jump onto, in Victoria, it's the Palliative Care Victoria website, but Palliative Care Australia has a website where you can jump on, select the type of specialist palliative care service that you're interested in, and then pop in your details and find out what services are available in your area. Now, if that doesn't work, then I think going to speak to your GP or to your oncologist or to your other health providers would be helpful, just to have a discussion about that.
So for someone, thank you. And that's really great that you clarified that. And I'll make sure that link to Palliative Care Australia and the state versions are all in the notes for people. So you'll be able to find those links a little bit later on today when I get to to putting that together. I talk to a lot of people from rural areas where there might be problematic symptoms. And one of the things about living with NETs generally, I think, is that our community learn very quickly that they need to advocate for themselves, because NETs behave in really different ways to other sorts of cancers. They get all these weird hormonal syndromes and weird stuff going on, and they find they need to speak up for themselves, and sometimes that means that they need to ask for a second opinion or a referral to a city centre when they might be regional. One of the things that I talk to people commonly, and this is, I'm sorry ahead of time because I'm banging on about a few of my little bugbears, but sometimes I talk to people where they've got, for example, pain, where it's not being managed, it's not being relieved by what the local service are able, like, you know, it's just not covered under their area of expertise, and we know pain can be so complex. Is it okay to ask for a second opinion for symptom management, as well as, you know, obviously if you've got tumours that are growing or that are squirting out lots of hormone, we talk about a second opinion to see a multidisciplinary team that's disease related, and they might then be looking at things like peptide radionuclide therapy or things that are only available in the larger centres. But what about palliative care? If your team, if you feel like they might be out of their depth, if they're kind of coming up with blanks and just saying, well, I don't know what to do for your pain. Tell us about what you would say.
Oh, that's a great question. And I'm presenting the ideal world here where palliative care is available and everyone will refer you. But the reality is that some health professionals as well think that palliative care is only for people who are actively dying. Would you believe I had a Facebook message from a consultant geriatrician yesterday whose grandma is in a nursing home with uncontrolled pain. And the consultant geriatrician had asked the nursing home, please, could you get palliative care to see my grandma? And they told her, no, she's not actively dying, you can't have it. So this is a geriatrician's grandmother in metropolitan Melbourne who can't get to see palliative care. So absolutely, you may need to advocate on your own behalf, you know, because neuroendocrine tumours are unusual and not many people have experience with them. And the spectrum of symptoms and diseases is quite wide. So it may be that if you ask your GP, oh, could I please see the palliative care team about my uncontrolled pain? They might look you in the eye and say, no, that's not appropriate because you're not dying. So that's that's a difficult situation politically, but you can jump onto the state website for palliative care. Often there's a button that says refer yourself or refer someone that you're caring for, and have a chat with your local team about what they can offer and what's appropriate. So they will need to get medical information from your health provider so that they're able to get you the best care. But certainly the local teams that I'm involved with, they will. I told my friend, the geriatrician, to jump on our local team's website and press the refer yourself button. And that's what she did yesterday. And today those referrals are in process. So there is ignorance in the medical community about the role of palliative care. when the baby doctors come on the first day to their palliative care teaching session, I can see the fear in their eyes, and they really are so surprised at the end of our rotation that we spend so much time on discharge planning and symptom management and keeping people out of hospital, because it is a common misconception that palliative care is only for people who are actively dying. And it's such a great thing that we're in Palliative Care Week, and the theme is palliative care, it's more than you think, because that's what the students always say to me. Oh, it's more than I thought. I thought it was just for dying people, but it's got lots of other roles as well.
And it's really interesting. I'm so glad you talked about referral, because that was one of the questions that someone put into the list of, when I said to the Facebook community this week, we've got Sonia coming in and she's going to talk about palliative care. Tell me your best questions. One person actually asked about self-referral, so that's awesome. I just wanted to pick up on your point about the fact that the baby doctors, the newly graduated doctors come and they look a little bit frightened about the thought of looking after people who are at the end of their life. And I just think, but they're not even doing it. Like, they're not facing the end of their lives. They're not facing the end of a loved one's life, but they're still a little bit frightened about it. And I think actually that speaks of a community perception that this is a subject that's deeply uncomfortable. And it's awesome that we've, I guess, helped dispel the myth that palliative care is about so much more than that. But I think that probably holds people back from a referral or talking about palliative care, because they're just like, they don't want to jinx themselves and acknowledge the fact that none of us are getting out of this alive.
Can I tell you a real story from last week? I was looking after a lady who our service had tried to see a number of times. She didn't have a neuroendocrine tumour, but she had an advanced cancer, and she'd consistently refused a referral to our teams. We'd been nice, we'd come in, we'd helped with her pain, everything had seemed to be going well, but she adamantly refused to let us make a referral to the community palliative care team, because she had that idea that palliative care meant dying and that she didn't want to die, so she didn't want to have the referral, which is totally fair, and we absolutely respect that. So she went home and then had a shocking 4 days at home with uncontrolled pain, and ended up calling an ambulance and coming back to the emergency department, which is, COVID central, and it was such a distressing experience for her. And she spent 24 hours in the emergency department and then was admitted. And then when we were able to see her, we fixed her pain up in about 12 hours, and she was so grateful. And I then had to come back to talk to her again about palliative care, because I didn't want to say it like this, but if we'd been able to refer to community palliative care last week, the whole thing would not have happened. We would have had injectable medications at home that the palliative care nurses could give her. She would have had a number that she could call 24/7. She would never have come within a bull's roar of going to the emergency department. We could have sent teams out from our hospital to see her at home. Her whole experience would have been so much better. And so after her pain was well controlled, I then broached this again. And luckily for me, this time she was very happy to accept that referral. And she said to me, "Oh, I'm so silly, I should have listened to you last week." And I didn't say, "Yes, you should have" at all. And she was able to go home with the security of having that number that she could call 24/7. And if her pain was difficult to manage, we could have organised a bed for her in our inpatient unit. And in the meantime, the palliative care nurses could have been coming out to her house, and they were able to give her injections of pain medicine so that she would not need to go in an ambulance to the emergency department. So that's just a real life example of where someone was so worried about palliative care that they refused the service, and that had a really big impact on how we were able to look after them.
I know it's quite a long time since I worked in community palliative care, so you might be able to help dispel any myths that I'm still, that I know things change. But I certainly remember when I was working in community palliative care, it was not that uncommon to be home with the 24-hour phone line support and all of the equipment and medications and whatever. But we'd often be able to book a backup bed in the local hospital, so that if things got out of control in the middle of the night, the person would be spared the ordeal of having to sit in the emergency department for hours, on end, and in COVID Central especially these days. Is that still something that happens where you can book a backup bed?
We used to do that, you're right, a few years ago, but we stopped keeping lists of patients who needed a backup bed, because when a phone call came in about a patient in the community to the inpatient palliative care unit, we would always take them whether or not we had that piece of paper there, and the piece of paper sometimes becomes out of date anyway. So we don't need to make a backup bed application anymore. But if a community team called us and said there's a patient nearby who's in a lot of trouble, they'd like to come into hospital, they will go straight to the very top of our list and we will take them as next available. And our job, we're so happy when the patient doesn't need to go to the emergency department, because that's a really terrible experience for everyone. So when I'm discharging someone from hospital, I'm always thinking in the back of my mind, what's our plan for if things went wrong with this patient? So for someone who's being actively treated for their neuroendocrine tumour, for example, and they had complications of their treatment, or something to do with their treatment that they're having at the hospital, they would come into the medical oncology wards. But if the patient wasn't having active treatment anymore and there was a deterioration in their symptoms or in their function at home, then I would discuss with the person and their family, what's our plan? And that plan might be to call the community palliative care team, and for them then to discuss with the person and family where they would like to be. Would they like to be at home being looked after? Would they like to be in a palliative care unit to be looked after?
So it actually sounds like there's a great deal of choice and control, but it's not, I think sometimes, again, there's the fear of, once you're on the palliative care train, there's no getting off, and it's going to the destination whether you like it or not. But it sounds to me like actually it enables greater choice in a lot of ways.
We hope so, that we hope to supply choice to people about what they'd like to do. So sometimes people, we always ask people, if your condition did deteriorate and if things became more serious, where would you like to be looked after? And we know that about 70% of Australians, if given the choice, would like to die at home rather than in hospital. But the figures are quite poor. Only about 15% of Australians actually die at home. So we're working to try to improve that.
So I guess, with all of the support services that are available, that's, that we might have greater capacity to be able to offer that to more people. But I'm also aware, certainly from my experience, that sometimes it's not until that the issue is that the palliative care team has only been sort of brought in at the 11th hour, and there's not really time to set things up so that can happen.
That's exactly right. Yep. So there's a push now for palliative care services to become involved earlier. The flip side of that is that I imagine would be quite common that if I was referred a patient who had an early neuroendocrine tumour and they were well and functioning very well and their symptoms were well controlled, that we might see them for an initial assessment and then we may discharge them from our service, which can be difficult for patients because they would like to keep seeing us. We really want to see patients where we can add value to their care. So we would like to get the early referral, and we like to discharge patients from our service if they're not needing it so much at the moment, so that we've got room to take in those new referrals of patients who really do need our service. So, yeah.
So if you've been discharged, sorry to break in, but if you've been discharged, so I spoke to, this is a person who I know very well, yes, who, this is the weird thing about neuroendocrine tumours, is that it can actually look dire, and they might be referred palliative care because it looks like we're kind of running out of plan alphabets, letters. Yeah. We've done plan A, B, C, D, and we're getting, like, things are ramping up. So they might have been referred to palliative care for symptom management and starting to think about those more confronting issues around end of life. But then sometimes the treatment will just start to work out of the blue randomly, which is awesome. So that person might be then, things get under control, their quality of life improves, they don't have so many symptoms, so they're discharged from palliative care. So this person, and you'll know who I'm talking about, but I'll try not to use any identifying language, but this person, that had happened, that we really thought, oh geez, it's not looking that flash, and we were all kind of bracing ourselves for things to not go well with this person, and they just, you know, they were given a different sort of chemotherapy on a bit of a punt by an inventive and creative oncologist. And
Yes.
what do you know, the liver lesions started to shrink, their liver function tests started to improve, and they're like, oh, party time, this is awesome. But they thought at the time what they were experiencing were terrible, terrible side effects from the chemotherapy. Actually turned out it wasn't. So, but that was what the person believed was happening, that I mean, exquisite pain because of, and they thought they had some ulceration in their gut that was leading to this terrible, terrible, terrible pain. But they'd been discharged from the palliative care service, so they didn't know that they could come back in and be cared for. So, but that is just, again, this is all about dispelling some myths. So am I right that you can sort of re-enter the care of palliative care?
No, we want you to come back. I just mentioned it because sometimes people are quite shocked and disappointed when they get discharged, but it's actually kind of a positive thing if you don't need us anymore. But for your patient that you're talking about, it would be 1,000,000% appropriate that they go back to the acute system to see the medical oncologist, because they need their new problem diagnosed with all of those appropriate tests. And then if it turns out at the end of those tests that the patient's disease has progressed and that a palliative care referral is again appropriate, then we're so happy to reactivate that. That's fantastic.
So can I ask for that patient? Now, actually what we discovered, which was so very delightful, was actually that it wasn't anything to do with the chemotherapy, because that patient was worried that they'd stop the chemo or reduce the dose and it would stop working, and so there's all the fears there. But we actually discovered it was completely unrelated, so that was awesome. But if the patient, so I guess I'm giving you a bit of a Dorothy Dix, because I've seen this happen where there might be side effects from treatment. For example, radiotherapy and skin reactions, or swallowing issues, or nausea, or those sorts of symptoms that can come because of treatment. Are you able to help manage symptoms that are very tricky to manage in that sort of situation when they're related to the treatment?
Absolutely, yes. So I guess there's two things. One is that we want the person to be cared for by the most appropriate team at the time. So I saw a patient yesterday, all these examples are so appropriate, who was actually having terrible nausea from their chemotherapy. So I was able to change around their medication to help manage that. But I let them know that the best point of contact ongoing, if my changes didn't work, was the medical oncology team who'd actually given the chemotherapy that was causing the problems. On the flip side of that, sometimes the medical oncology teams will come to us and say, this patient has dreadful hiccups from their treatment, can you help? So a lot of my job when I'm working in the consultation service in the hospital is to help manage side effects, not just from the cancer, but from the treatments as well. So we just want to make sure that the person gets the right care at the right time. And I think that the palliative care services have a really good idea of where our limits lie, and when we say, actually, no, I'm not going to just increase your morphine for your pain. You need to talk to your medical oncologist now, because I'm worried that you've got this particular complication. So it's always a little bit of a dance, and we can't make a hard or fast rule. It just depends on the situation.
It sounds like a really fluid mechanism between, and that it's really relying on really good communication between teams.
Yes, communication and teamwork, and that's why talking to everyone about what palliative care is so important, because we don't want those doctors to say, I'm not referring to palliative care, it's hiccups. Palliative care is only for end-of-life care. We want to have good communication and good referral pathways so that everyone can get the right care at the right time.
So I think that's another myth I wanted to dispel, and I know people have emailed me questions, and I swear I'm coming through them. Are we okay for time, Sonia? Because one thing I forgot to check with you is, are we all right to keep talking for a little bit longer?
Keep talking.
Awesome. Absolutely. Okay, you let me know if you've got to go and see a patient or something. The question was about I wanted to dispel a myth about, I think. I've got my brain's telling me it's Friday afternoon, it's time for more coffee. I think the myth I wanted to dispel was about palliative care being only about pain, because you mentioned hiccups. So can palliative care, again, a Dorothy Dix question, because I know that there is an answer to this, but so hiccups, you can do things about
hiccups is my favorite. I love hiccups because there's specific known causes for hiccups. No one knows about this stuff, and so it's very satisfying to come in to someone. I remember someone who'd had hiccups for 3 weeks. They couldn't sleep, they couldn't eat, they couldn't talk. They were so distressed. And I was able to just run through a little bit of an algorithm of getting rid of some of the causes of hiccups and then putting in some medications to stop the hiccups. And, it's so satisfying to be able to help someone with terribly difficult symptoms. I've got 2 specialty symptoms of interest. One is itch and one is cough. And both itch and cough have unbelievably terrible impacts on people's quality of life. People have actually become profoundly depressed because of the impact of cough or itch or hiccups or other symptoms on their life. So one of the fun things in my job is addressing a really tricky symptom, especially, this is a bit naughty, but especially if other people have tried and not fixed it, then it's really fun to come in and fix it. So, yeah.
So I'm hearing that you like a challenge, but I think it takes a special kind of palliative care doctor to say, I really like cough, but I really like itch.
Cough
is hilarious.
Because often their life is so impaired by cough, especially for women who've had children and they have some incontinence with it, and people in COVID times stare at them in the street when they go out. It's so socially disabling. There's physical, social, emotional components to people's distress from symptoms. So that's really fun for me.
So that's interesting that you mentioned about physical and social, and that it's, you sort of alluded to the fact that obviously these symptoms, there's a physical experience with them, but there's often an emotional experience, there's a social experience. Often people are deeply questioning the meaning of their life, so there's like a spiritual aspect. Can you talk about the role of palliative care? We've talked about it not just being for pain, but it's not just for physical stuff, is it either?
No, that's right. So I think the most amazing thing that community palliative care does is that they give someone a phone number to call, and someone will ring and check in with them about how their symptoms are going. It's giving that emotional support to know that there's someone to ring if things get difficult. The community palliative care team also have family support workers or social workers that can help people and their families as well deal with the emotional impact of having a life-limiting illness. They have occupational therapists and physiotherapists who can help move equipment into the home to enable better care at home. So it's not, pain is kind of the it's not easy, but it's the obvious thing that we do. But the other sorts of supports that palliative care can offer are around functioning, around emotional support, and having an ear to talk to about problems as well.
I know each service is slightly different, but we've got one person who's really active in our Facebook group, and I know she's talked openly about how helpful it's been. She's actually had a volunteer, and they couldn't come during COVID, but she had a volunteer come, and they were helping to write her biography. So
yes, life reviews. Yeah. My mum actually did one of those when she died with Eastern Palliative Care in Melbourne. A volunteer came and sat with her and wrote down her life story, and we took photos and actually made an amazing book about my mum's life. And luckily she was able to finish it just before she died. It was just an amazing thing. And palliative care can also help. Some people have young children and are not sure how to speak with them about their illness. Palliative care teams can help with that as well. Of course, I'm talking about the ideal situation. So I hope that everyone does have a good experience with their local palliative care team. And as you mentioned, in some areas it is more difficult, especially in remote areas, to get these sorts of services. One good thing about COVID is that about half of my outpatient consults now are on telehealth. So we don't want people to come in all the way to hospital if it's not necessary. So we do a lot of our work on telehealth and provide those services to people in remote areas, which is really good.
So that's worth exploring, and I always think it's worthwhile. We know that not every service is going to be the same, and it might be a little bit more limited in regional areas, but also I think sometimes there's beautiful advantages about regional services as well, in that for a lot of people I know, they tell me it can feel really intimate.
Yes.
Because there's that small community that really kind of gather around. So, it sounds like it's absolutely worth exploring, and these are some of the things that might be available to you in where you are.
Definitely.
Someone asked me a really good question, which is, what sort of things should you do before seeking a referral or making a self-referral to palliative care? And the sorts of things that they were talking about were enduring power of attorney or an advanced care plan. Is there anything that people should do, or does that come with the palliative care territory?
Yeah, so you don't need to do anything before having a referral to palliative care. We would just need to know that you had a life-limiting condition, and we would need some medical information about that. But I'd love to talk about those aspects of advanced care planning. Everyone should do advanced care planning, not just people who've been referred to palliative care. And some people are not sure what advanced care planning is, but it's really simple. If you were really sick, say you got COVID, and you went to the emergency department and you were so sick that you couldn't talk to the doctors about what care you wanted and what care you didn't want, who would speak for you and what would they say? So the first bit, who would speak for you? If you were so sick and you couldn't talk, the doctors would want to ask what your views were, what sort of treatments you wanted or didn't want. We need to know who that person is that you'd like to speak to. And there are different names for this in every state, confusingly. In Victoria, it's medical treatment decision maker. In other states, it's medical power of attorney or enduring guardian. And you can find out the relevant information for your state from advancedcareplanning.org.au.
And there'll be links in the notes.
Yep, fantastic. And the second thing is, what would that person say if the doctors were talking to that person that you've chosen about what treatment you'd want? Does that person understand what your wishes and healthcare values are? And the most common thing is just for you to have a conversation with your substitute decision maker about what sort of treatments you want or you didn't want, or what your values are. But some people can also put those in written forms, which is called an advance directive. And I just really encourage everyone to jump on that website, click on the page that talks about the situation in your own state, because it's different in each state, and get some information. So, if you become unwell, who would speak for you and what would they say? That's the summary. You do not need to do that before coming to palliative care, but actually everyone should do that, because anything can happen at any time.
I think that's a really good thing to highlight, Sonia. And I actually did a workshop on this yesterday, so it prompted me to have a look at the website, at the Advanced Care Planning website, which I'll put in the links. But actually there's a little tile for each of the states, so it makes it really, I found it really easy to navigate to, the information that I was looking at, because I was like, I think I need to talk with my parents, and probably I need to do this for myself. Damn it. But it was easy to navigate to the information that I needed. The other thing I wanted to say was that it also prompted me to get in touch with Advanced Care Planning Australia, and we have a speaker lined up for in August. So we will be looking at this in our Facebook Friday community in a lot more detail in a couple of months' time. So maybe your advanced homework, people out there in Facebook land and YouTube land, is maybe before we had that speaker on board, have a look, and so I'd be really interested to see people's reflections on that process, and have a think about the sorts of questions you might like to ask that guest expert when we tackle that subject in August. I think it's incredibly important. And again, speaking from the perspective of having been having worked in palliative care, sometimes things happen that are unexpected, and the person, it's hard for them to express what's going on. For example, if they've got a lot of shortness of breath, or if they are very tired, and it's very fatiguing to try and express what they want. It's just so much easier when the families say, oh, we talked about this, 5 years ago or whenever, we talked about this. I know, I've had, like, for example, I had a patient where, and I'll never forget it, because it was so beautiful, that the person had said, I am passionate about Andrew Lloyd Webber's version of Cats. And I'm like, takes all sorts. But they really wanted to have the soundtrack of cats playing as they slipped into unconsciousness. And so we were able to get that queued up, and I was there in the middle of the night, and it was beautiful because we knew that that's what that person wanted. But it took a lot of that guesswork and stress out for the family, and they were feeling really confident that they'd done all of the things that their loved one had asked them to do, and they felt less stressed. And everybody was, being wafted along by McCavity the mystery cat. But like, as I said, it takes
I
all
would find
sorts.
that stressful myself, but
I know, like, as I said, all sorts. But yeah, so I just got a
that is
comment.
so important. And I also have some homework for everyone, which is that if you have done any of those documents, you've appointed a medical power of attorney or a medical treatment decision maker, or you've written an advance directive, pop a copy in the post to your health services that look after you, and they'll pop them on their medical records so that those will be available if you do become unwell. And what you said about the families was so true. We know from medical research that having those advance directives in place reduces anxiety and depression for family members of the person who is unwell.
So we often think, well, we don't think actually, but often we avoid things that feel confronting or stressful because we're sort of frightened of them. But actually, this, in terms of the overall effect, reduces stress.
It does. It really reduces stress. I cannot tell you the number of times I've looked at a relative in the emergency department and said, what did Maureen want? Have you talked about it? And they look back at me in horror and say, we didn't think things were going to get worse. We didn't really discuss about it. And then it's so stressful for that carer to have to try to make decisions in those situations. But just to come back to the original question, you definitely don't need to do that before you see palliative care, or indeed at any time. It's a totally voluntary process.
And it seems like something that everybody should do. So not only should all of our patient community get on with it, but they can nag their kids. If their kids are saying, you need to do your advanced care plan, and you can say, well, so do you. So
exactly, I'll do it if you do it.
Yeah, I'll do it when you've done yours. So I had a couple of other questions, and this is probably everyone's wind up, because I know that everyone will need to have some lunch and a drink soon. But if there's any questions that you've got for Sonia that you would like to put in the comments, I can see some great conversation and lots of smiley faces and saying hello and things, which is awesome.
Awesome.
But I've got a couple of questions that I was very curious about. Yes. So I'm going to spring these on to you, Sonia, and give everyone a minute to just sort of type madly if they've got things they want to ask. The first one was, you mentioned before about you've got a look of glee when you started to talk about itch and cough and things. Like, I think one thing that I know about the palliative care doctors that I know is that I think they're pretty awesome people, and they're clearly very, very passionate about what they do. And I just that's a really precious thing I think we have in our community of teams that look after people with cancer and other illnesses. What was it about palliative care that drew you to this?
So that's a great question. So I was a very junior doctor, perhaps second year when I did my first palliative care rotation. And up until then, as a junior doctor, you just follow a lot of orders. So you write charts and you write medications and you order tests that you've been told to do by your more senior doctors. And when I did my palliative care rotation, it was the first time that I had ever really made people feel so much better. So that was a really profound experience for me, to have someone come in, for example, breathless and in pain, and then in just a few hours have them much more comfortable and not frightened anymore, and the family is so relieved. That's a very rewarding thing to be able to do. And then when I, after that rotation, I spent a long time doing my medical training, and I just watched sometimes people have awful experiences in the health service where they were frightened, they didn't have control, they didn't have symptoms that were well controlled. Sometimes they died really poorly, just died in a way that you wouldn't want to happen to anyone. And at that time, it was in the late 90s, and palliative care was just becoming a formal specialty. And so I jumped into the training scheme in 1999, and I think I was only the third purpose-trained palliative doctor in Victoria, but it had been more advanced in other countries and in other states. And I don't regret it, because we have such a great chance to help the person in front of us with symptoms and their families, but also to influence the health system to improve the care of the people that we will never meet. So I want the junior doctors that I teach who go off to be a respiratory doctor in Ballarat to be really confident with using medications for breathlessness. So I think that's why I got into palliative care.
Well, it sounds actually, and I think probably the motivation was similar for me from a nursing perspective, that opportunity to feel like you're really able to make a difference.
Yes.
It is extremely rewarding, and that opportunity, but also that opportunity to, at a community level, create greater awareness and a high level of comfort and create change and better services is it's a really exciting thing to be able to be part of as a health professional. So
and nurses in palliative care are so important and so influential as well, you know, really prominent part of our team. So thanks for all your work.
we think it's awesome. We think it's awesome. So the other question I had, and I just, there was a, there's two comments that I have to read out to you. The first one is, I'm late because I was getting my palliative massage. So
oh, wow.
Awesome. You can catch up on the conversation on rewind.
I would endorse that. You should prioritise wonderful experiences such as getting your massage.
Yeah, absolutely. And then the other person who has just put a comment in, which I just think I want to let you know, is that they've just said it's more comforting than ever expected, and well done. And so I guess that's what, that makes my heart sing a bit, because that's what I wanted it to be, that, you know, I think we as a community, we're scared about this. And one of the things that I loved about palliative care when I started to work in the area that really struck me was how much laughter there was in the wards when I was working in inpatient palliative care, but in people's homes, and how much, you know, we can help dispel that tension and the worries and things, and actually then that lets people just, you know, laugh and have joyous times together. So that's I'm really happy that that's an observation that someone's seen from this conversation.
I'm so happy too. That's wonderful. And I hope that anyone ever does talk to you about palliative care, that you don't automatically think that it's a terrible thing, that it means that the person thinks that you're about to die. People refer to palliative care for so many different reasons and in so many different ways. So inpatient, outpatient, community, or consultation teams in the hospital. There's so many different reasons and different ways that we engage with palliative care. So if we can convey that message today, then I'm so happy as well.
Yeah, awesome. Sonia, I just have one more question if you've got time. And everyone's just going really interesting to watch, and I'm going to rewatch it, someone said. So, you know, that's exciting too. The other thing I know that you are doing some research and some study. So I'm interested because we're broadcasting via a Facebook group, and this is going to go up onto YouTube. And so working with social media stuff is a bit of a different way of working for doctors, and a lot of people who, I mean, I'm so grateful to all of the medical health professionals who Zoom into these Facebook Friday broadcasts, because it can be a little bit confronting, you know, knowing that you're going up on the screen and that you're, you know, that the things that you're saying and the care that you're providing is in a really sort of non-traditional way. Can you tell us about the stuff that you're looking at the moment, please?
Oh, so I think there is a gap between the information that healthcare providers are providing to patients and the information that they need. And that difference is demonstrated by the engagement of patients and health providers in social media. So, for example, groups like this are an amazing example of an online community where people are asking questions, answering questions, exchanging information, and building a community that cares about each other. Doctors and health services are not engaged in that to the same extent. We do put out some information about the research that we might have done, but there's a bit of a disconnect between health providers and between patients in social media. So I'm about to launch into a sabbatical leave in digital and social media. And as part of that, I'm studying a postgrad dip at Curtin University in digital and social media. And I'm hoping to get more of a handle on how health providers can better use social media and digital technologies to improve the experience of patients with cancer.
It's just, and when I heard that you were doing that, I thought this is actually pretty much the reason that I reached out to you, Sonia, to do Facebook Friday, because I thought if she's doing some research and study into the area of social media and provision of information for, you know, health services, then maybe she'd be willing to say yes to the Facebook Friday experiment. So it's really interesting, and I think one of the things that strikes me in my role at neuroendocrine cancer is that, you know, we've got people from all over Australia, and so there's people who, you know, their hospital has an app where they can look at their reports and things from their scans, and they can get their blood test results and all of that sort of thing, whereas other people have a lot of trouble accessing any kind of information in that way, and they're like, well, where's our app? And so I wonder, is your research going to look at that kind of interface as well, or is it just like, you know, Twitter and Instagram and Facebook and YouTube and that sort of interface?
Yeah, so I think that is really interesting moving towards, it's about patient preference and patient ownership of their information. I think that's really important. Imagine if we couldn't log on to online banking. Like, it's unthinkable that we couldn't log on at the bank and see what our bank balance was. But up until very recently in Australia, it's been almost impossible for patients to log on and see their own results. So yet that's part of the digital strategy, I guess, of health services moving forward, to explore what sort of information would be helpful and useful for patients, but not harmful. We need to make sure that we don't provide information in a way that could be upsetting or detrimental to the person, while still being very honest and disclosing fully all the information that's relevant.
Yeah, and I think you're right to highlight that complexity, Sonia, because I know from, again, you know, I've had the privilege of sitting in on multidisciplinary team meetings from time to time, and I hear the conversations where the radiologist has looked at the scan and said, oh, you know, lesions here and here and here of, you know, they're doing this and this and this, and looking at that initial report, it can look a little bit alarming. But when the multidisciplinary team look at that report, or at the actual scans, they go, oh no, that's not an important change. Or so sometimes it's about the actual information, but it's also about the interpretation of the information. So I think it's going to be really interesting to see how this space grows, because I think people, it's their information. So like you said, you need the access to your online health banking. But also there's that interpretation there that can be a bit more nuanced and complex, and often does need a conversation with a health professional to work out.
Absolutely. Especially with neuroendocrine tumours, which are quite uncommon and they're quite heterogeneous. So there's lots of different forms and types and prognoses, and the doctor looking after you has very specialised experience in that area. So any questions that you've got about your particular condition or situation are always better addressed to the doctor caring for you and the nursing team caring for you as well, because they're so experienced and knowledgeable in neuroendocrine tumours. So I think that's exactly right. We need to strike a bit of a balance between making all the information available and also talking to the nurse looking after you and the doctor looking after you about your own situation.
Awesome. Well, look, I'm so grateful to you, Sonia, for joining us. I don't think there's a billing code for doing a Facebook Live broadcast, and so I know that this is sort of eating into your own time, and I just so appreciate it, because you've been really generous with your expertise, and I think your enthusiasm for tricky symptoms and improving things for people to live well at home for longer, it's infectious, and I feel really inspired having spoken to you, and I know from the comments that people who are watching have just been so encouraged and helped by this conversation. So thank you so much.
Excited. Thank you so much for having me. It's been an absolute pleasure.
Fantastic, thank you. So what I'll get you to do, if you want to, I've got a little tiny bit of housekeeping and news for that, and I didn't warn you about this bit, but I've got a little bit of housekeeping and news for people before I log off. So you're welcome to press the little red button if you would like, and we'll say goodbye to you, and thank you so much once again.
Thank you. Awesome. Bye, everyone.
and it's just me. So I'm going to not take long because I know I can really ramble at this point in the day. There's 3 things I just wanted to let everybody know about. The first thing is that next week on Facebook Friday, we are kind of taking there's a bit of a contrast look at fertility and cancer. And so last year we did a couple of sessions looking at sexuality and neuroendocrine cancers, and maybe I'll have a look at that event and just make sure the links to those videos are up in the notes in case you want to refresh your memory. Sexuality is a topic that is a bit like palliative care, isn't it? That it's a bit taboo, but we know that anyone with a neuroendocrine cancer or any sort of cancer, it affects every aspect of your life, and so sexuality is one that is definitely up there for people. For people who are of childbearing age, the fertility aspects of having a cancer are also really affected. And so I've got a couple of experts who are going to talk to us a bit about fertility preservation, but also for people with a family-linked genetic predisposition to various types of NETs, but particularly things like MEN1 we hear about in our Facebook group, people who have pheochromocytomas or paragangliomas, where there might be an identified genetic syndrome that is, linked through the family. So there are now technologies available where people can undergo IVF and they can selectively choose embryos that don't carry that trait. So I'm really looking forward to talking with our experts, and I should have written their names down. It's Sharon Stockmeyer and Dr Fleur Cottrell, who will be catching up with us next week on Friday at 1 o'clock in Eastern States time. So I'm really looking forward to seeing you then and hearing all of your juicy questions ahead of time. So I'll, if you're in the Facebook private discussion group, then please do reach out and let me know what you want me to ask them. So this is, obviously we want this to be useful for you. Just a couple of other things. Second thing is just to, and this is really for the purposes of our Facebook private discussion group. So if you're watching on YouTube later, just feel free to disregard it. There's been a lot of conversations, may I say a lot of conversations about COVID and vaccines. We know that this is an area that's really fraught for a lot of people. In our Neuroendocrine Cancer Australia services, we always endeavour to be giving people the best evidence-based information that we can. And we're aware that sometimes conversations will verge into things that are about experiences and opinions and advice seeking, where that advice is probably best directed back to that person's healthcare team. So if you were struggling with a decision about whether or not to have a COVID vaccine, in our Facebook private discussion group, there is a pinned post with links to all of the very current evidence-based information and guidance for people with neuroendocrine cancers. We're not engaging in those conversations in the group space very much. The other thing I would say, just to our general Neuroendocrine Cancer Australia community, is that my emails have been really dominated by people emailing me, and I love it that people feel confident and comfortable to send me an email going, I don't know whether to have the vaccine, and which vaccine can I have? And I love talking with you all, but it does mean when I'm answering emails like those, there are people who are emailing me who are newly diagnosed, and so that can sometimes lead to delays in me talking with people who are really struggling with aspects of their neuroendocrine cancer and their diagnosis and their symptoms and all that sort of stuff. So I'm trying to be, I will be quite brief if someone's emailing me with questions about the vaccine, and I apologise in advance. I don't want to appear abrupt or brusque, but by the same token, I'm just aware of my role in providing more broad support for people with neuroendocrine cancers. And I can't advise you, as a nurse employed by a not-for-profit charity, I can't provide you with individual advice about dosage and treatments and vaccines and things. That really has to come from your medical team. And have a look at the pinned post on the Facebook private discussion group. I'll make sure those links are in the YouTube notes as well, if you're still watching and hanging in there via YouTube. The other thing, just lastly, is that I'm super excited that despite coronavirus being very much a presence in Melbourne at the moment, I'm hoping that that's a short-lived experience, but more generally, we've done a lot of work behind the scenes in COVID safe planning, and very excited to announce that as of next week, we are returning to face-to-face support groups for all of those groups that have been hanging in there via Zoom for the last 12 months. So next week we've got groups meeting I think we've got a social gathering in Adelaide. I think we've got a group booked for Brisbane and a group booked for Perth. So if you're not getting emails and information about those support groups and you would like to be part of it, my contact details will be in the notes. And we're sending, everyone who is part of those group invitations will get a copy of our COVID safe plan. Make sure you have a read of that because that's really important too. But yeah, I'm just so excited. We were going to have, there was a Melbourne gathering for a social Melbourne gathering this coming weekend, which a lot of people were very much looking forward to. And can I just say that I was going to go to that too, and I'm disappointed. And COVID, I guess, is just teaching us all to be, I'm just taking the policy of writing everything into my diary and pencil this year until we've got this thing sorted out. So I just, reaching out with my thoughts to everyone who was hoping to gather in Melbourne, and we're in lockdown, so we're not going to be doing that, but hopefully we'll be able to reconvene at a time that is not so full of virus in our wonderful city. So look at that, I'm going to leave it there. It's been lovely to chat with you all. Thank you very much for your positive comments. I hope you enjoyed the conversation with Sonia as much as I did. As I said, I think her enthusiasm was infectious, and I feel really delighted that we were able to bring that to you today. So I will see you next Friday talking about fertility and all things related to that. But in the meantime, my contact details will be in the notes if you need to get in touch. Take care, everybody.